I'd like to begin with a patient who I met a few years ago. When Tyler was 3, he developed lymphoma. Thankfully, with anti-cancer therapy, he went into remission and led a healthy and productive life for the next several decades. Unfortunately, 20 years later, he presented to our emergency department with acute heart failure and cardiac shock, a situation where the heart is no longer working effectively to pump blood to the body. The cause was determined to be the anti-cancer therapy he received as a child. This is an example where life-saving anti-cancer therapy has an adverse effect on the heart. These conditions that cause cardiac problems are what bring me to you today. My name is Dr. Sakima Smith, and I'm a heart failure transplant cardiologist. But importantly, I am also a translational physician scientist who has developed a research program to understand how anti-cancer therapies can lead to cardiac injury and heart failure. We have graduate students and postdoctoral fellows performing cutting-edge research using various cellular and molecular models to understand the basic pathways where anti-cancer therapy can damage cardiac cells. As heart disease is the #1 killer of cancer survivors, this research is critically needed. I want you to walk away knowing that a new field of cardiology examines the interface between cancer and heart, and we are investigating novel breakthroughs to protect the heart for those who are receiving therapy. Essentially, we're trying to understand how to protect the heart for some of the adverse effects of anti-cancer treatment. In this talk, you will hear me mention a new word, cardio-oncology. This is a new field that has developed over the past decade and really has accelerated in the past 5 years. We've understood some anti-cancer therapies for decades, and we know that they are effective. Anthracyclines, for example, are known to be a very good treatment for breast cancer, but it's also known that they can lead to the development of heart failure. Yet, these mechanisms remain evasive and elusive. What really propelled the field forward was the fact that anti-cancer therapies have become so effective that patients are now living longer, to the point that the #1 cause of death for cancer survivors is heart disease. So, this has led to a surge of collaborations between oncologists and cardiologists to understand why these drugs cause heart disease and to come up with better treatments and methods to monitor the heart during anti-cancer treatment. So, God forbid, let's say you or a loved one is diagnosed with cancer. Traditionally, what would happen is that you would see an oncologist who would then form a treatment plan. There would be some basic cardiac testing to screen the heart, including ECGs and echocardiograms, which are ultrasounds of the heart. But typically, unless you develop cardiac symptoms, there would be no follow-up cardiac testing. Hence, you could slowly develop a heart problem from the anti-cancer treatment, but the ability to detect this early to prevent long-term damage will be missed. I think the ideal scenario would be if an oncologist is treating a patient, they would then screen you at baseline with the novel biomarker, which is a blood test to detect heart damage. And then you would have follow-up screening with the premise that this blood test is so sensitive and so specific that it can pick up early warning signs of heart damage before you develop any symptoms, at a point where any early heart damage is reversible. So that really is the key. Can we identify a novel blood test that we can then use for routine follow-up? And by doing the science, we hope to understand some of the pathways that lead to toxicity and repurpose these medications that are already on the market as heart protective medications. These heart protective medications will then be administered at the time of receiving anti-cancer therapy, thus protecting the heart and allowing you to receive the life-saving benefits of anti-cancer therapy. There are a few institutions that have already established programs, but just a handful. So, with Ohio State being involved, we're at the forefront, as there are only maybe 4 to 5 established programs in the entire country. We feel that we are well positioned to be one of the leaders, national leaders in the field. I know you know about the Ross Heart Hospital, and I know you know about the James Cancer Center, but this will allow us for the first time to have a scientific collaboration between both institutions in this new exciting field. Between these two institutions, we have the patient volume, we have the nurses, scientists, pharmacologists, oncologists, and cardiologists, and all of the resources to have a world-class cardio-oncology program and be a national leader in a very short amount of time. It's imperative to have a multidisciplinary and collaborative science, because to really do this type of work in science, you need to work with clinicians, nurses, basic scientists, cardiologists, oncologists, and pharmacologists to really develop a formal program. We're excited to have Dr. Dan Addison as a section leader for cardio-oncology in the Division of Cardiology, and he has already developed a national reputation in the field, as evidenced by his research, publications, invited talks, editorial board service, and curriculum development. Furthermore, we're actively recruiting faculty members and trainees to formally develop our cardio-oncology program. The plan is to have consultative services, clinics, research programs, and training programs where a patient can present to the clinic in the James and during that same visit see a cardiologist, pharmacologist, receive cardiac imaging ECGs, screening blood tests, and have routine follow-up with a care team with the focus on protecting the heart while providing top-notch anti-cancer therapy. For those in the audience who are interested in discrete science in our lab, we're doing very basic and preclinical studies using different cell lines and tissue samples to understand mechanisms and to develop cardioprotective strategies and new cardio-oncology specific blood tests and biomarkers which can be used for routine follow-up and screening. We're testing different anti-cancer medications and different heart protective drugs in cell cultures to understand which ones are really effective so we can then transition to preclinical proof of concept studies. This is novel work being performed right here at The Ohio State University that could impact patients across the nation. We would like to show that a drug that's been on the market and is already FDA approved can be used in a different purpose as a heart protective therapy for people who are receiving anti-cancer therapy. Hence, the takeaway from our research program is that we are developing follow-up strategies with novel blood tests to detect early warning signs of heart damage, and we're pursuing heart protection by repurposing drugs. This is critically important as new drug discovery can take 15 years and billions of dollars. So we're essentially fast-tracking that process by using something that's already approved on the market and just using it in a new way that could potentially help millions of people. With respect to the anti-cancer cardio-oncology space, we are actively submitting grants to the National Institute of Health to support ongoing efforts. We're in the early stage of trying to secure funding to support this program. Hence, our new research program doesn't happen without generous early-stage philanthropic investment prior to any federal funding, and hence we are very grateful to the Fricks and others who have helped us get started. If you have a passion for our science, I invite you to join us on this journey as we continue these early steps to combat heart disease and cancer survivors, as we need everyone invested in this critical mission. Let me finish with Tyler, who, as you may recall, presented to me a few years ago essentially on life support due to a failing heart from anti-cancer therapy he received as a child. He initially did well with medical therapy after his initial presentation with cardiac failure and shock. 3 years later, he received a mechanical heart, which is a mechanical pump that is implanted in patients with heart failure. It helps the bottom left chamber of your heart pump blood out of the ventricle to the aorta and the rest of your body. That is why it is called a left ventricular assist device. A year later, he received a heart transplant. He's actively doing well. He's out in the community, educating people about the importance of organ donation. In the future, with the research and growth of cardio-oncology, ideally, people like Tyler will never develop a cardiac problem after receiving life-saving anti-cancer therapies. Thank you.